Good morning. This is Barbara DeLoyne talking to you from the Colorado Department of Public Health and Environment. And we are delighted that you are here today. We'd like to welcome you to both the webinar as well as to those of you who are attending in person. We have 23 who are signed up for the webinar, which is wonderful considering this is our first effort that we have. Sorry. Wouldn't you know my phone would go off? And I'm just learning to use this phone. I apologize. We have 8 here attending at the health department. And so this is really a nice turnout for the NICU Consortium meetings. I would also like to thank Jane Gerberding, who is the nursing consultant for the health department here for the healthcare program for children with special needs. And I'd also like to thank Laura Zuniga, who is helping us coordinate this webinar today. So thank you to both of you. We have 2 presentations today. I will begin talking about tools and resources to facilitate discharge to a medical home and community initially, and then we will have a break from 10 to 10:30, and then Krista Beckworth is going to be talking with us about promoting maternal mental wellness to the health of the next generation. And before we started the webinar, we were talking about some of the research that is showing the impact on toxic stress for families, and one of the things that we do recognize is that all families, whether they have a baby with special health care needs, a premature infant, all can benefit from knowing about resources in the community. And we really want to work together to identify ways that we can get this information out to families. One of the things I also want to mention for the webinar, in case any of you are not familiar with this, is that all of you are muted, and if you have questions during the program, you can type in your questions on the screen that's at the lower right hand of the of your screen, and Laura, who's monitoring those, will let us know what your questions are, and we'll stop when we see questions come up so that we can answer them. The same is true for those here in the audience. If you have questions, please feel free to raise your hand. The other thing is that after the webinar, we really want to get your feedback about how the webinar has gone for you, information about future topics that you would like to see presented. And so you will be getting a very short survey that will enlist your feedback about the webinar and our presentations this morning. So please do respond to that. That's the way that we know how things are going. I also want to mention that we will be having these quarterly NICU Consortium meetings. Depending on our success today with the webinar, hopefully we'll be able to continue the webinars into the future so that we can reach out not just to those of you in the metro area, but really across the state as well. This is a wonderful opportunity for us to connect with our partners in many of the different rural areas of Colorado, and we hope that you will spread the word about the NICU Consortium, and not just with the community, but also with your local hospital staff. We want to include them as well as primary care providers and other agencies who are taking care of young children. So with that, I will begin my presentation. And I wanted to begin with some information that we have shared with many of you over the years, basically to kind of increase awareness of the population that we are talking about. I think when I have presented before, most people don't realize how many premature babies are born in Colorado every year. And this doesn't necessarily include term babies who may have special health care needs, such as infants with congenital heart defects or respiratory illnesses, metabolic conditions, genetic conditions, who are born after 37 weeks. So we actually don't have an accurate estimate of the total number of babies, but we can say that we have around 7,000 or 8,000 babies born prematurely, low birth weight, in Colorado every year. And one of the things we know is that the moms of these babies often experience health disparities in accessing health care services. We also know that these babies are more likely to have regulatory issues. That means issues in feeding, in sleep, in fussiness, and cause parents not only stress from having the experience in the NICU, but experiencing the difficulties once they go home. We also know that this population is much more likely to be readmitted to the hospital after they go home due to jaundice, feeding problems, low weight gain, to respiratory illnesses like RSV. And therefore, what happens is there's increased medical care costs and additional stress and cost to the family. Because of this, we believe that these families need additional community support, and that is really what one of the goals of the NICU Consortium. What I'd like to point out to you is, again, as I mentioned, this is an estimate, and we don't have very accurate data, but we can estimate that we have approximately 68,000 to 70,000 babies born every year in Colorado. Again, that number is actually down a little bit over the last 5 years because probably of the economy. Families realize that they need to look at their finances before they have a baby because of the expense. We also want to point out that of those babies, approximately, and I'm using the March of Dimes Peristats that are available on the web, approximately 7,000 to 8,000 babies are born prematurely. And we'll use that kind of as our basis of numbers. We also know that if we look at Part C, our early intervention programs, that they are doing a wonderful job in reaching out and meeting the needs of babies who are born less than 1,200 grams or have an identified problem in the NICU where there are developmental delays. The problem that I want to point out to you is that from the 8,000 or 7,000 or 8,000 babies that are born with prematurity, if we just deduct then about 2.5% of the babies that are covered by our early intervention programs, that still leaves us with around 7,000 babies who go home from the NICU, who are born and what we often consider our late preterm infants, who go home without being necessarily connected with our local community supports. And that is one of the reasons that the NICU Consortium has really begun. To give you a little bit of background about the NICU Consortium, it was begun by a group of local public health nurses who have been concerned for many years about this population, as well as the premature babies that are under that 1,200 gram weight. They hope with the NICU Consortium that families of babies discharged from the NICU will be informed about appropriate health and community services. We recognize also that not all families are ready at the point of discharge to have someone come into their home. And actually in my presentation today, I'll give you some interesting information about that. We hope to promote a coordinated system of discharge and follow-up for these babies in their community, so that parents are connected with community resources, including their primary care provider, that we can reduce parent concerns, and we really hope that we may be able to actually decrease infant morbidity and mortality. Again, this population does have a higher incidence of infant morbidity and mortality. We also want to make sure that we focus on best practices as families transition home, and that is the kind of the background of why I wanted to present information today, because there is a lot of information out there that will guide us in our practice. The consortium membership is open to anyone. There is no charge, and it's a broad audience. Public health nurses, staff from the NICUs, the hospitals, from primary care offices, community partners, and family advocates. We hope that by having this event quarterly, which comes on the 5th Wednesday of each the years that have, or the months that have 5 Wednesdays, we have a chance to get together and just connect, learn about community resources, and talk with one another. We hope those on the webinar may consider that in your community that you also invite others to attend the webinar and then are able to have your own in-person meeting wherever in your own community. We also have this wonderful opportunity of education and learning from one another and learning about community resources, as I mentioned. The goal of the NICU Consortium is that we'll have a representative from the public health staff as a connector, if you will, with the local hospitals. That we have sort of the local hospitals have someone that they can call if they're wondering about community resources. And similarly, if we know of opportunities in the community or resources that are new in the community, that they can communicate that back to the hospital staff. We also hope that the primary care providers will be involved as well, so that primary care providers know about what the community resources are. Okay. This is an example of what we have done in the metro area, and this can be available on our with links. Right now we have identified key contacts in our local public health departments that are able to provide nursing support when these babies go home. Not all of them can provide home visits, but they can talk to families and help them get connected with community resources. We also have some of the offices, such as Tri-County, that actually has a special infant project, and their focus is on that late preterm baby, those babies who are not eligible for the Part C program, who are essentially pretty healthy going home, and then they can be enrolled in the Special Infant Project or SIP program for actual nursing home visits in which they have a nurse come into the home. They are able to counsel the parents on feeding and sleep, different areas of concerns that the parents have. They provide developmental surveillance by using the ages and stages questionnaire if the pediatrician or primary care provider is not able to do that. And they really work with the family over that first year of life. And then after that baby is a year, they look at what other community resources might be needed. Some families who have a child maybe that identified more medical problems might then be referred on to the Tri-County Healthcare Program for Children with Special Needs. So that is an example of what we're trying to do here in the metro area. We would love to be able to see that expanded to other areas of Colorado. So my objectives for you today are really to talk about and encourage this interdisciplinary collaboration and the continuity of care for the premature and medically fragile infants. There are resources out there. We don't have to start from scratch. And this is just an example of some of them. So, okay. So these, here at the in-person meeting, I have examples of all of these different resources. It's pretty impressive. And what I'm going to do is kind of highlight some of the issues or some of the resources, material that are available in each one of these today. Okay. I'm going to start really with the NICHQ Neonatal Improvement Project. NICHQ stands for National Institute for Children's Healthcare Quality. And I want to draw your attention to numbers 8 and 9. This is a group that really looks at the NICUs and what are best practices for NICUs. And they have very specific types of recommendations for the NICUs and different quality standards, which are absolutely able to be implemented in the NICUs because they're a more closed entity. They can work together with the neonatologists. They can work together with their staff in order to really identify best practices. What happens, though, is when these babies go home, there's a break in that continuity of care. And we hope to really overcome that. So I'd like to go through just some of the things that they are recommending that would be interventions or ways that we can implement a better system. So, under intervention number 8, coordinating NICU discharge, involve the families. We all know that. We talk about family-centered care and how we can establish that. Helping families realize that there are resources for them when they go out into the community is a first step in that. And I know in talking with NICU nurses, it's very tough because one of the things is that they know these families. They have worked with these families for 3 months. And oftentimes they really want to continue that relationship with the families. And what I think we can work on is beginning to help families in that transition from the NICU to the other community providers and educating families about the value of that. Maybe not initially in the first 2 weeks, but certainly over the first year of life. Written and oral, whoops, sorry, Laura. Written and oral communication, instructions, families need written information, we all know that. But again, that written instruction is also passed along to those who are going to be caring for that baby when they get home. Identifying specific resources, really a lot of what we're talking about. And again, oftentimes families, they've been through the NICU experience and they really want to believe that everything is going to be normal. And in fact, in my own dissertation, that was what families expected. I'm going to go home and everything's going to be fine. But as one mother said to me in my discharge, in my dissertation, she said, I thought everything was fine when I left the NICU. But when that nurse called me, and this is with Kaiser Perinatal Home Care, where they do have nurses that visit when the babies go home, she said that nurse couldn't get here fast enough. I had so many questions within 24 hours because there's a nice controlled environment where they're practicing. And when they get home, it's like, okay, but this happened and it didn't ever happen in the NICU. What do I do now? Okay, number 8 and number 9. So again, I think it's interesting that both 8 and 9 talk about increasing communication on the discharge team and the accepting community organizations. How do we do that? They also talk about the importance of neurodevelopmental follow-up and some type of developmental surveillance. Many of you know we have a very significant initiative in Colorado, ABCD, really getting developmental surveillance and monitoring of all children in primary care offices. The problem is not all offices have been able to implement that right away. So sometimes we need a support system for the primary care providers because they have many other demands on their time. And so how can we support those primary care providers in our community settings? And again, one of the things we know is that the struggle is we don't have a lot of funding for this type of follow-up program. And again, that's where our advocacy comes in. Okay. So to give you an idea of what the American Academy of Pediatrics says about the discharge of high-risk neonates, they define the preterm infant, not just the low, very, very low birth weight babies, but all preterm infants. They define infants with special health care needs or technology dependency. And again, remember I talked about those babies that might go home with cardiac conditions, genetic, metabolic conditions. Also infants that have families, maybe with some risk issues. And an infant with anticipated early death. And I think sometimes we have some wonderful programs for hospice and butterfly program, but are we connecting and are we communicating with those in our community agencies as well? Okay. So to identify some of the infant risk factors, you'll see them here. They're probably not unknown to us, but how are we looking at that in the hospital discharge process? Are we really doing a systematic and thoughtful process of looking at what a family, what a baby's risk factors might be? And I'm going to propose I can have come up with just a very one-page sample of how you might take a look at that. Maternal risk factors are next. A lot more, which I think a lot of times in our NICUs, in the hospital, we're so focused on the baby, because that's who we take care of, that we don't think about, what about the moms? And I will share with you that in my own dissertation, I was researching what it was that families needed when they went home from the hospital. And I also was very focused on the baby. And I did not inquire or even collect any data on the mothers and what they had been through. What I learned is that there's a reason those moms delivered a baby prematurely. A lot of times, it's because they have their own risk factors. And we don't really look at those very often. And again, if you look at breastfeeding for these moms who are taking babies home from the hospital, these also are factors that will influence the baby's ability to breastfeed and the mom's ability to really sustain that baby with breastfeeding. And so what we're finding now is we're doing a great job getting moms breastfeeding when they go home from the hospital, both with term babies as well as our preterm babies. But what is the resource for them once they get home? What kind of follow-up do they have? So that when that baby starts to, sleep all day or all night, how do they make sure that they know how to wake that baby up and get that baby to eat? I'm not going to read that list. It's pretty, you can read it yourself. So this is an example that I came up with that just lists all of these different issues. And basically, it's almost like a checklist that you could begin to consider reviewing at the time that a baby's going home. So you can sort of say, wow, this baby only has one of these many elements. You know, it's probably going to be okay. But you begin to see that there's a baby that maybe has some high-risk factors and a mom who also has a lot of risk factors. That's probably one you want to begin to think about. What are other community resources we can hook this family up with? So again, what are some of the other recommendations when it comes to the discharge of these infants? There's a wonderful educational program provided by the March of Dimes that actually provides continuing education. It was developed by Susan Sachs and Susan Blackburn, who are very well known in the neonatal community in terms of helping families. And they talk about the factors that increase parent stress, which you'll see here. I think one of them that's very interesting is the whole timing of that first scheduled visit to the primary care provider. And I know, again, from my experience, that oftentimes we will schedule that appointment, but how often are we making sure that family has transportation to get there? And I know a lot of these parents who are going home, and they have to get their baby on the bus in order to get to that first primary care appointment. And guess what? Here we are giving them all this wonderful information about car seats. You know, what happens if they're on the bus? Another one, feeding. We know that is a huge issue for these babies when they go home. And as I mentioned, breastfeeding is more common now, and moms have much more difficulty with feeding. The other thing that Susan and both Susans talk about is an assessment of the home environment. And I will tell you that early on in my public health experience, I actually did get a referral. It was from Arizona for a baby going home from the NICU that wanted me to make a home visit to the family before that baby was discharged, just to let the parents know that there was going to be somebody there when their baby went home, and sort of make sure that they had some of the basic necessities for that child. These are examples of just some of the types of things that they have included in this home assessment. This is another one, and I mention this because, again, both the American Academy of Pediatrics as well as the March of Dimes are talking about this family and home readiness for families to bring these babies home. I was precepting at Children's and received a referral to a home visit on a teen mom, and she had a late preterm baby. And unfortunately, at 1 month, that baby had not regained birth weight. And so, as part of my clinical precepting experience, I offered to do a home visit. The home visit revealed to me that this mom was in a group home. She was living in a bedroom that was probably barely big enough for 2 twin beds. She was with a group of other teen moms. She barely had equipment for pumping, for breastfeeding. She had an old breast pump that was not effective. And even the preparation, the kitchen, was very unkept, as you can imagine, with a group of 8 or 9 teenage girls. The kitchen was not very clean. And so her ability to even prepare a clean bottle of formula was compromised. It really kind of reinforced to me the importance of that. So these are some of the things that others are recommending that we consider in terms of readiness for those families to go home. The other thing I want to mention to you is that if you think about all the information that families have to learn at discharge, whether they've been there 3 months, which actually is a little bit easier, or if it's a late preterm and maybe they've been there 2 or 3 days. It's a lot of information. And for those of you who've had children, you probably also remember how much information you can absorb and retain in a very short period of time, and that's another problem for these parents. I know as at Kaiser, when I worked there, I would do the discharge teaching on parents, and I wanted to give them the best discharge teaching. And I talked about everything. And then I had the opportunity to do a home visit a day later. How much of that do you think they remembered? Almost none. And I asked them, where's your pamphlet on breastfeeding? What? Huh? You know, it's in the bag somewhere in the back room. And so I learned in my discharge teaching what is the most important information they need to remember for the first 24 to 48 hours. And then I will be able to talk with them on that second or third day about additional information. Because there's just so much for new parents to learn. Okay. So this, again, is another example. These are all the topics that we're expecting parents to remember. It's a very long list. And in fact, when I was doing this, that's one of the things that struck me is how much information we're expecting parents to learn and remember once they go home. And then I also thought about the fact that, okay, then we're asking the primary care provider who has short visits with families and, you know, is expecting to any more today, they might have 15 minutes, if they're lucky, to see a new baby right after the hospital, and they're going to be reinforcing this information. So I really feel that we have a role in partnering with our primary care providers to support them in the information that is provided to parents. Okay. So this is another thing that Susan and Susan talk about, is sort of this pre-discharge visit. And we actually, when I was actually working as a public health nurse with Tri-County recently, one of the NICUs actually connected a family to the HCP program before the baby went home. This was a family who had a baby with Down syndrome, and they were very educated. They knew that they wanted to get the best resources for their baby, so they called the HCP program and requested a nurse visit to talk with them about community resources. It went very well. I mean, again, this was before the heightened anxiety of going home and actually having the baby at home. So my guess is these parents were much more prepared when the baby went home and had been able to retain a lot more of that information. Again, we don't have systems to do that necessarily, but part of our advocacy role, I think, is to be communicating if that is important, if we find that important for families. So how does it, again, we're talking about the preterm infant. A lot of times we think about those very low birth weight babies and how at risk they are, but they both talk about, and I think we will see this, it's the late preterm baby. And remember, this is that 7,000, maybe 6,000 or 7,000 babies that are going home in Colorado every year who are late preterm. These are the babies that are generally not eligible for the early intervention program. And we want to make sure they get access to resources as well as the higher risk babies. The other thing that we have learned from our Special Infant Project I mentioned earlier, as well as some of the data from Boulder County's follow-up program that they have implemented, is that about 25% of the babies that they have picked up that are not enrolled in early intervention actually are referred to early intervention within that first year. So this is another piece of information why it's important to really identify and connect these families with the resources that they need. Early intervention is a wonderful program, but we want to make sure we connect all of the babies that can benefit from it. So the other thing that in this training program that they talk about is listed here. Some of the things that we don't even think about sometimes in our discharge teaching is issues around siblings, and I can tell you, having visited families at home, trying to breastfeed a new baby and having a 3-year-old running around is almost impossible. And that's hard to prepare families for that in the NICU, because it's a contained environment. But you've got a mom and she's at home and the 3-year-old is just, wanting to be on her lap at the same time. Doesn't work. Issues around fussiness and crying are also another big issue. That there's no way to prepare parents for that. And we absolutely, when I think about shaken baby syndrome, we know that all too often it's probably instigated because of parents not having support and not having the ability and information about how to calm a fussy baby. Some of these other things are also up there, that growth parameters. We know that sometimes these babies just don't feed as well and end up with more difficulty in weight gain. Again, special topics for each family. Okay. Susan's talk about the discharge summary and some of the issues that need to be included in the discharge summary, and what information needs to be shared with the community provider. I will tell you that oftentimes we get information on the babies when they come home, and that parents have a copy of the discharge summary. But unfortunately, one of the things that isn't identified is the maternal risk factors I mentioned earlier. And remember that slide that showed how many maternal risk factors can impact the care of these babies. So keep that in mind. Okay. So for any of you that might be interested in reviewing this particular continuing education program, you can obtain it from March of Dimes. This is the website that you can go to, and it's very reasonable for those of you both in the hospital as well as in the community. I recommend maybe taking a look at that. Okay. Some other guidelines I want to refer to is March of Dimes. A lot of times we think of March of Dimes being so active when it comes to prevention of prematurity, but they also have wonderful materials for the discharge planning and follow-up of these babies. Basically, they talk highly about collaboration among family, primary care, and community. Begins during pregnancy, and this is something in reading the guidelines that seems like a no-brainer when you think about it. If you have a mom that has a high-risk pregnancy, why are we not connecting with them early? And unfortunately, a lot of the families that have moms with high-risk pregnancy, because it's identified in that second or third trimester, these are families that are not eligible for the Nurse-Family Partnership Program. Nurse-Family Partnership has to identify families in the first trimester. And so we have a population who in the second and third trimester are at risk, and we have nothing that I'm aware of to connect them. And I have somebody nodding at me, so I want to see what she has to say.
No, actually, yeah, we would like them to be 16 weeks, and that would be into the second.
Okay.
So we can take them 1 month postpartum.
Okay.
And that is state mandated.
And that is Nurse-Family Partnership?
Yeah.
Okay. So there have been some changes which we will share with you. Basically what I'm hearing is that they can take them up to 16 weeks prenatally.
And anywhere through pregnancy.
Anywhere through pregnancy now.
We
Wonderful.
We prefer them 16 weeks and earlier,
okay.
But we can take them all the way up to 1 month postpartum.
Okay.
But yeah, we prenatally anytime.
Okay. So what I'm hearing is Nurse-Family Partnership can take families all the way through pregnancy and 1 month postpartum. So that's a great resource that maybe we need to disseminate that information. That's wonderful. And then they would follow them, I assume, up until the 2 years of age, similar to all the other families. That's a great resource.
And
Sharon,
one of the serious restrictions is that's only first-time moms.
Right. And Sharon Langendorf, who is also here, pointed out that is only for first-time moms, which, again,
it's still wonderful.
It's great, and we need it. But again, we need, when we have 7,000 babies out there, we need to get to them. And Nurse Family Partnership obviously can see that greater population, not just the high-risk babies as well. So great, thank you very much for your information. So these are other guides, and again, that's part of the reason we have this NICU Consortium, because it's a way to get information out to the community. But I think that's important. We really need to be thinking about pregnancy as a time that we can identify these families and begin hooking them up with resources. The other thing I want to address that they talk about is that we need to recognize mothers' reluctance to reach out for support and sort of this sense of isolation. And in my career, this is something that I have often found. We talked about it briefly before the webinar started. And that is families, when they go home from the hospital, they need some time to just normalize and to sort of pull things together and rejoice in the birth of this baby. And oftentimes when we offer resources in the hospital, they're not ready to hear that. You know, they really are at a point where it's going to be fine. I mean, you really want to believe in the best. And so they don't really feel like they need resources at that point in time. But what I have found is that sometime after they go home, and generally speaking, they talk about it, readiness to connect to resources at 4 to 6 weeks. My own experience would really confirm that within that first month or two, that's when they begin to have questions that they would like to connect with resources. My own experience has told me that if they don't get connected with resources somewhere around that 3 to 4 month time period, that they have gone through the worst time. And what they will say to me is, you weren't there when I really needed you. I don't need you now. And I think we need to be sensitive that there's a critical period of time for families when we need to communicate that we care, you know, that we know that, you know, the best is going to happen for them and their babies, but that if they have questions down the road, we will have someone there for them. And that is something that I think I haven't seen written anywhere else except within this, within these guidelines. And you'll see that goes back to 1996. And again, this is kind of an algorithm that they have, that they share in this document, and I could not find it in print anywhere. I think it's out of print. But again, I stress that in this algorithm, they talk about helping families through this transition. Again, they start at pregnancy, and they talk about the transition that families go through from pregnancy, you know, really through the first years of life. Whether we're talking about transitions from the hospital home, or from, I should even begin, from the OB doctor to the hospital to the primary care provider. And then we begin thinking about, okay, well, they also are going to be going back to work. What are the transitions that families go through with returning to work? And I don't mean just the moms. I mean moms and dads. Dads experience a lot of stress when they have to go back to work. Another time is when, even when the mom or the grandparents leave, you know, and that they're going back home, and now they have to take care of this baby and the house and the toddlers and everybody else. Another transition might be in that second 6 months of life, all the transitions with development and feeding, where all of a sudden you have a baby that wakes up in the middle of the night when they were sleeping great for a while, right around 9 months of age. And also they find that right around 9 months of age, they're trying to begin to help them eat solid food, or they think they should, and that baby really likes breastfeeding, and they're not too sure about taking all that other stuff in. And so the moms go, well, I'll wait another month, and I'll wait another month. And so then we begin to see them in our feeding clinics because the babies are refusing to eat any solid food, and their weight is going down. And Nancy Krebs talks a lot about the importance at 6 months of helping those families transition in that second 6 months of life to solid food.
And if he was really born 3 months early, that's not at 6 months.
Exactly.
Right.
Sharon Langendorf points out to us that 6 months for a preterm baby born at 3 months is not a 6-month-old. And we also have to work with our primary care providers to help them understand that feeding readiness for a preterm infant is not based on their chronologic age. It's very important to adjust that age. And sometimes we need to advocate for the family. I've had teen moms or young moms where they were so anxious to get that baby to eat solids, get off that expensive formula if they were on a formula, to, just a lot of things like that. And that's where sometimes we need a team to help in communicating with our primary care providers and sort of pulling that team together to provide a support for that family and educating the family, making sure we're coming across with the same message, that we don't have the primary care provider saying one thing, early intervention saying another, WIC saying another. We all need to be on the same page for the families, because believe me, there's nothing worse than having families hear different information from different providers, because guess what they do? They're going to pick which one they like best, which may not be the best one. Okay. So there's another discharge guidelines for technology-dependent infants. This one, again, is also not in print, but I think it's important to recognize all the technology that families are coming home with today and differentiate what it is that home health care services provide, which are really the hands-on information. And that home health care provides a wonderful service for families. They do wonderful teaching. They provide a lot of support for families, especially those families who are going home with a ventilator for oxygen and multiple medications. However, what I found when I was working with a home health agency on one particular child is that they're not necessarily connected with community resources. And so there was, you might say, well, it's a duplication of services. You've got a nurse in here with home health and a public health nurse, but our roles are very, very different. Public health nurses are there to provide connection with community resources, and actually what I found myself doing was becoming a family advocate in that situation, where the family, because of cultural differences, because of communication issues, they were really not able to advocate for themselves. They were so angry after coming out of the NICU that all they did was spew anger in a lot of the situations. And they needed somebody to help communicate and get the resources to help them deal with their mental health issue in order for them to be better able to communicate with the home health agency. And again, it's a wonderful tie-in with the with what Krista is going to be talking about later. The other thing they talk about is the guidelines, and in their guidelines they point out the importance of home environment and community resources again. I think one of the things I also like to point out that they talk about is what are the outcome criteria for these infants with technology. And one of the things I want to emphasize to you all that I learned again in my dissertation is all too often we talk about education and teaching families. But what the families explain to me is it's not really this spewing of information to them. What they really learned was about problem solving and decision making. And I think if we begin to think about our education along the lines of how are we helping families problem solve? How are we helping them make good decisions about their baby? How do we help them when it comes to when do I call the doctor because my baby's got a stuffy nose? And who do I call? Do I call the primary care provider or do I call the pulmonologist because it could be RSV? How do I know when it's appropriate time or that the doctor has told me it's fine to give my 28-week preemie at 6 months corrected age, solids, and I'm going, my baby can't even hold their head up very well. Why would I want to be giving solids? That they can challenge. They can go back to the doctor and say, you know, I'm really worried about this. So they become an advocate for their baby as well. Okay. So another area that I want to talk about is the late preterm infant. And this guide is a wonderful guide. It was developed in 2010. And these are some of the topics that they relate to the preterm infant, or late preterm. And I have pictures in here of my grandson. You know, I've always been wanting to have a picture of my grandson. And this is Cole when he was born at 36 and 6/7 months gestation, or weeks. And you'll see him now at a year, at his 1 month, or his 1 year birthday. He, you know, it's so funny because many of you who are grandparents will appreciate this, that you can have all the wonderful information that you want, but my daughter-in-law was much like many parents. You know, they wanted to go home and they didn't need grandma around the house. And yet when she got home, they went into the doctor. Cole went home like about a day or two. She had been in the hospital for placenta previa for like 6 weeks, and believe me, she was very ready to get home. And so they went home and went back to the doctor. Well, they had to go in every single day because his temperature was not stable. And they were like, of course, my other grandson, who was 3.5 at the time, was another piece of the of all that was going on. And so she was very upset because she said, well, the nurses didn't tell me that I was going to have to worry about his temperature. She wanted very much to breastfeed. Well, she was so worried about the temperature that the breastfeeding just kind of went into the back corner because they were going in, and he had a little bit of jaundice, and he wasn't, you know, nursing very well. And so, I mean, he really was typical in the terms of what we begin to see in these late preterm babies. Okay. So this is another guide. Look at all these wonderful guides that we have available to us. As I said, we don't need to go out and create the wheel. This was done by the National Perinatal Association, and I'm very pleased to say one of our own Coloradans, Ellie Yost, I noticed, was on one of the, involved also in the development of this program, and Ellie is with the National Nurse Family Partnership Program here in Colorado. This provides a wonderful resource of materials from really from all the way from the hospital to the home environment. And you can get this online and download it. It's very available. It provides information on you know, topics to look for and even recommendations. So Laura, go ahead.
And I think just the nice part about it too is that it has the baby plus the mom involved in there, so that you've been stressing that. I just wanted to make sure.
Yes. And what Jane Gerberding has pointed out is that it focuses both on the mom and the baby, which I think in our mindset that is, there is no baby without a mom. I think Joy Brown, I will give her credit for that. She says that, you know, that is our patient or a client, however we want to couch it. It is not just the baby. It really is both. And we need to be thinking about those moms and what they're experiencing and make sure that we're not only assessing this baby, what the baby is doing, but how is the mom doing? How is the dad doing? What is the couple doing? We know that parents who go through this experience have higher rates of divorce and a lot more stress. This is an example, and I did not know this. There's a lot of good information in here. Again, the late preterm were likely to be hospitalized within 2 weeks of discharge, but this is something I didn't know, that the morbidity rate doubles every week less than 38 weeks. So if we look at a 34-week preemie, these are our late preterms that we're not identifying, has a 51% greater chance of morbidity. So we really need to have a better surveillance system for these babies. Okay? They talk about the key topics that are provided in this document are stability, screening, safety, and support. I kind of like that as the 4 S's. to be thinking about for, again, these are the different categories, both in the hospital, in an outpatient primary care setting, short-term follow-up, and long-term follow-up. So this is the kind of information that they provide in this document. I also, another resource to share with you, because breastfeeding, as I mentioned, has really become the standard of care for our families, all babies, and those moms who are in the NICU will, I mean, I can't even tell you how hard they work to get their babies to breastfeed from the beginning all the way through to the time that baby is discharged. They must pump, for those of you who may not be aware, anywhere from 6 to 8 times a day, just sitting in front of a breast pump and pumping. They have access to that in the hospital, and there's a lot more support. But that takes some dedication.
Especially getting up in the middle of the night.
Exactly.
They're exhausted.
Exactly. Sharon points out they have to get up in the middle of the night at home. The baby's in the NICU.
Small home, lots of people, turn on the lights, bothers other people sleeping, everybody's frowning at you.
Sharon points out again, and I can see this image. Small home, maybe apartment, you've got all the family members there. Mom's going to turn on the breast pump, turn on the lights, and wake everybody up because she has to pump. It's a huge effort that they go through.
Hopefully she has the technology that's available at the hospital to actually do that in a short period of time versus some of the ones that go home with parents or don't go home with parents and they have to figure that out once they get there.
These parents, whether you're a late preterm or preterm baby, to have a good hospital-grade breast pump is critical. I work with a teen mom, again, my dissertation, where she pumped, the baby was about 2 months early, and she pumped absolutely, was dedicated for 2 months. And she had established wonderful breastfeeding for her baby, but she went home, and she could not get a breast pump. And within 24 hours, her milk supply had dwindled down, and despite a wonderful lactation consultant that was able to come and visit her at home on a daily, almost every other day basis, she was not able to get her breast milk going again. Now that was in 1998, so I hope we could say we're doing better now. This is a program which I just want to share with many of you, especially if you have new nurses in your setting or lactation, early interventionists, social workers, it doesn't matter. We all can learn more about breastfeeding and how to support families. This is an online course. It is free. Mary O'Connor, who is with Denver Health, along with Linda Lewin, created this course, and they are updating it and upgrading it, with new information. And it provides wonderful information about the preterm infant as well as the physiology, the benefits of breastfeeding, medications. It's an excellent program, and for many of you who maybe are interested in exploring this area a little bit more, I highly recommend it. You take it at your own pace. So if you didn't do too well on the post-test, you can go back and take that section again. And I have done it myself, and I did it through my lactation consultation program, but you don't have to. You can do it as an individual. And so I highly recommend it. And again, the link is there. What I'd like to talk to you about briefly, unfortunately we're sort of at is the toolkit for the follow-up of preterm infants. And I'm just briefly going to go and show you the website. And Laura, we can go to that website now, so you can see it. I'm actually going to move around. Or actually, Jane, if you can help Laura. Do you know how to navigate? Yeah. A little bit. What I want to show you is this is the toolkit. So if you will go to the toolkit, you click in there, and you agree. You enter. And you agree, and what you will see here is the toolkit for the follow-up care of the premature infant. This was developed through NICHQ with the support of MedImmune and brought together members of the Academy of Pediatrics and many, many other excellent leaders in the field of maternal and child health. And what they did is they wanted to develop resources to support the follow-up of these babies. And what you'll see here is there's the introduction, but up at the top under discharge planning, you can click there, and they actually have resources, PDFs, if you go to maternal history, documents that you can use either in a paper document, and it gives you a guide, like this one sheet. If we could get this one sheet out to our primary care providers, it would then advise them of what this mom's medical history had been. You know, that would be very, very helpful. So, and it's very easy to complete with some checkoffs, okay? At Stanford, they're actually implementing this toolkit into the residency program for the medical students or the docs. We might think about that maybe in our nursing education or all early interventions could help. Discharge, and so if we'll go back and look at the neonatal history, so you can see, you can print these off as PDFs, and you can, there's no logos on here for MedImmune or anything. They give credit down at the bottom. But the toolkit also, this has for the neonatal history, and it also has one then, too, for a discharge checklist. In your handouts, for those of you who are attending here, these are in there, but it's really much better to go to the website and explore them. And if you go back to the home page and then scroll down, what you'll see under discharge planning, you'll see at the bottom, under each of these links, you'll see great resources. Now, sometimes it'll take you back to the AAP website. You don't want to do that. We'll cancel. Yeah. So go up to outpatient follow-up. I don't think it took. Oh, there it is. Okay. So go down to initial visit form. So here is what a primary care provider, or even, I'm even saying that if you're doing nursing home visitation, if you're an early interventionist, you could use this form as a kind of, what are some of the information I need to collect to know about this baby? Maybe some additional questions, and then you've got a nice, easy resource for your record system. And basically, this has a front and a back. And on the back side, I don't know if you can go. On the back side, it kind of has some more information about what you need to be thinking about. Like one of the big things, there we go, go down. So you'll see here, referral and follow-up appointments. These are kind of things as a reminder. What do you need to be thinking about for referrals? And one of the big areas I think we need to be very sensitive to is the whole issue for those babies who are eligible for Social Security disability insurance. Because a lot of families don't know about that until their babies are much older, and that is a good resource for them. Okay, so what these visits do is for every single visit, from the initial visit all the way through the first year, they have a form like this, so that at the 9-month visit, it's a little bit different than obviously it would have been at the initial visit. It also has wonderful resources. You'll see links to Bright Futures and other specific information. If you go to specific medical issues, this is another wonderful resource to kind of review. These are the types of medical issues that might be of concern for this population. Again, whether it is the preterm term infant with healthcare needs, I think that we can be thinking about that. Okay. And then if we'll go to the parent or caregiver, but you could see this is a wonderful resource. These are actually parent educational information sheets that you can download. Vision, hearing, immunizations, infection prevention, nutrition and feeding, safety, additional resources. A lot of information is on this. And if we'll go back and one more A couple more tabs to the tools. Again, anticipatory guidance. There's one item here I want to point out. Under growth development. If we can look at care, whoops, go back. Yeah, care of premature monitoring growth and development. Oh, that's going to take us out. Sorry.
Oh, sorry.
Okay. But there's one great one on breastfeeding. There's materials on nutrition and what these preterm infants need for nutrition. So you can see, let me look here. Go down. Nutritional deficiencies. I'm trying to make sure that we, yeah, look at that. The PDFs are going to come up. That's a good one. Okay, this is a one sheet, but it talks a lot about the need for iron and vitamin supplementation for these babies. Again, we're learning a lot more about the nutrition of these infants, and really, it's not, and again, you learn so much in doing a dissertation. I was so focused on the weight of the babies when they went home, I did not look at length or head circumference. What I have since learned is that you better look at head circumference and length as well. And all too often in a primary care office, remember how they do the length for babies? Put it on a sheet of paper and you mark it at the head and you sort of stretch the baby's head out on the paper and you mark it at the bottom. That's really not a good way to do measurements for preterm infants, because what happens is, and a lot of times, especially these babies that are being G-tube fed, they become very, very chunky, and they look kind of round cheeks and round little bodies, but they're not growing lengthwise. And so we have to make sure that they're both growing in their weight as well as their length and their head circumference. Okay. Well, I see that my time is up by about 5 minutes. A lot of information. And I invite you, if you have questions about this, please let me know. I'd be more than happy to talk with you individually. What I want to stress to you, and if Laura, you could go to my slides again, because the one that has all the colored squares on it. Down, down, down. Okay, that one. What I want to say, if you're familiar very much with motivational interviewing and the need to really identify what it is that parents care about, I have come up with sort of this as a draft. It's certainly not evidence-based at all. But the purpose of this is that when parents, when we go in the home and we say to them, well, now what kind of questions do you have? What would you like information about? And Christy Blakely, who is very active and has been in Family Voices, said, that's like going to a restaurant and having the restaurant say to you, well, what would you like to eat? What would you like for your dinner? And she said, but you don't know if you're an Italian restaurant or a Chinese restaurant. She said, we need a menu of services or of topics that parents can pick from. We can always have another column. But this is kind of my first attempt, and I keep actually adding on some things. You know, we might have to break it down even more and say, well, do you have any questions about feeding? And then have, you know, these are different topics that other parents have had questions about. It kind of gives them permission to say, yes, I'd like more information, or yes, I really could, you know, it's okay to ask questions. So I really wanted to point that out to you, and you know, it would be great if we could begin to develop this in a collaborative way and then begin to share it and test it out a little bit. So I thank you all for your time. We will now have a break until 10:30. For those of us who are here, we do have coffee and we have some snacks, but we will meet back at 10:30, and Krista Beckwith will be our speaker. So thank you all for joining us. Welcome back. This is Barbara DeLoyne, and I would like to welcome you back to our second half of the NICU Consortium meeting. And as we begin, one of the things that I want to also do is recognize the public health nurses that have been really instrumental in seeing this come to fruition. they are Kathy Bolajak, who is at Tri-County with the HCP program, Molly Benkert, who is at Denver Health, and Carolyn Quinlan, who is at Jefferson County Public Health, Lori McLean, who is at the Boulder County Health Department, Michelle Anslavar, who has been with Tri-County and was with the Special Infant Project for a number of years, has moved to California, but we're very happy that Paula Carrasco is our new representative with the SIP program at Tri-County. And we really have to recognize those individuals that have had the vision and the foresight to expand this group of that met for many, many years as public health nurses and saw the benefit of modeling after what Lori McLean had done up in Boulder and what Michelle and Kathy Bolajek had done in Tri-County, and seeing that, you know, we could really reach out to our hospital colleagues, our community partners, to expand and serve our families better in our community. So I really want to recognize them. It's now my pleasure to introduce Krista Beckworth. And Krista is with the Colorado Department of Public Health and Environment, and I'm going to let you tell about her background a little bit and the work that she's done, and then she will go on to talk about promoting maternal wellness for the health of the next generation. And I think that we were talking a little bit at the break about the mom and baby at-risk assessment guide that can be available, and how many of the items that I just reviewed for you that were in the documents, in the guidelines on preterm infants, but how many of those issues relate also to what Krista's going to be talking about. So thank you very much, Krista.
So as Barb said, my name is Krista Beckworth, and I am a maternal health specialist with the Maternal Wellness Program at the Colorado Department of Public Health and Environment. I guess some quick background about me. I'm a Colorado native. My master's is from Johns Hopkins out in Baltimore, and most of my background has included MCH work as well as communicable disease, specifically in the areas of HIV and hepatitis, both nationally and then some international work as well. So I was brought here today to really help ensure, as Barbara said, that focus on mom as an extension of the baby and thinking about mom throughout the entire process as well, and what she might be at risk for. And first, we're going to figure out how to work the webinar. Like this one. Oh, there we go. Okay. So today we're going to talk a little bit about what pregnancy-related depression is as one of the many perinatal mood disorders that mom can experience, and risk and protective factors and the impact on the family, as well as learning about some of the other risk factors that could be happening, like substance abuse, intimate partner violence, etc. And then we'll talk a little bit about what we at the state level are doing in some of our work moving forward, because that's really how we were brought into integration with you all and some of your work. Okay, so depression is the most common complication of pregnancy. According to our PRAMS data, which is the Pregnancy Risk Assessment Monitoring System, between 2009 and 2011, almost 1 in every 9 pregnant women noted that they experienced depressive symptoms. This is actually, we think, is underreported. On a national level, estimates fall between 15 and 20% of women who will experience depressive symptoms. So it's definitely an issue here in Colorado. And so the first thing I'd like to do is actually show you all a quick video about the 2020 Mom Project. Have any of you heard of the 2020 Mom Project? Excellent. And oh, we have one. Oh, good. We have one in the room that has heard of this before. So this project has originated in California, but the intention is really that this project wants to have a national impact, and their approach is looking at hospitals and insurers. This is one kind of stem of what we're looking at in Colorado, but I think that it also really highlights some of the issue well, and even better than what I can just do in slides. So this is really exciting if this works.
Did you know that mothers give birth to 4 million babies in the U.S. every year? Let's face it, it is a joy, but also a challenge to enter motherhood. There are a lot of diapers to change, feedings, crying, sleepless nights, learning to care for a new baby, dealing with hormonal changes, and more. And new moms are expected to rest and recover with all of this. It can leave any new mom feeling overjoyed, but exhausted, overwhelmed, irritable, and anxious. During this transition, 80% of moms will experience the baby blues, which can include tearfulness and sadness, inability to sleep, changes in appetite, and self-doubt about being a good mother. The blues generally last a couple of weeks. But up to 20% will go on to experience something more serious, like postpartum anxiety or depression. These conditions are the most common complications of pregnancy. The problem is that most of these moms will never get the help they need. Here's why. First, most expecting and new parents are never told about maternal mental health disorders. Second, there is a shortage of mental health doctors and therapists, and not all receive training in maternal mental health, and those who are qualified to treat are not easy to find. Third, most OBGYNs and pediatricians do not screen moms for maternal depression or anxiety because of a number of obstacles, like lack of time and not knowing where to send moms for help. All of this makes it a broken system, and as a result, hundreds of thousands of moms and families suffer in the U.S. every year. But we can solve this. First, let's recognize doctors alone cannot solve this problem. Since most moms deliver at hospitals, and millions more will have health insurance because of the Affordable Care Act, the 2020 Mom Project sets forth an alternative path to change by focusing on what hospitals and health insurers can do to help. For example, what hospitals inform women and their families during childbirth classes about symptoms of maternal mental health disorders, whether they are at greater risk, and common triggers such as sleep deprivation? What if health insurers identify maternal mental health specialists in their directories and help moms find treatment? What if OBGYNs have posters in their office listing the symptoms with an 800 number to call for help? These are just a few of the changes the 2020 Mom Project recommends. We believe that together, these simple steps can lead to a big change by the year 2020. Learn more and join the movement at 2020momproject.com.
Okay, so I think that video kind of gives a good snapshot of both what we're looking at nationally, because this really has become more of a national focus, and then what we're also looking at locally. There we go. So in Colorado, we use the term pregnancy-related depression, and we define it as depression that occurs during pregnancy or up to 1 year after giving birth, including after a pregnancy loss. This is also commonly referred to as perinatal depression, maternal depression, postpartum depression. There's lots of different names out there for it. We specifically kind of landed on this for a couple of reasons. One, we wanted to be inclusive of a mom who may not end up carrying the baby to term for whatever reason, and also moms who are not even the person who carries the child, so somebody who adopts could also be at risk for some of these symptoms. And then also to be inclusive of fathers and partners, because they can also be at risk for, oftentimes we hear it being called paternal depression. However, I think to be more inclusive of whoever that partner might be, partner-related depression, or we want to be inclusive of kind of the whole spectrum of it. So we've had a lot of talking internally, and we think it's fascinating that we have had almost universal screening for gestational diabetes, which only really affects 3 to 4% of the pregnant population, yet there's hesitation to do universal screening for depression during pregnancy or the postpartum period. And there's lots of reasons, and what we have found in Colorado is that many providers don't know what to do. That there's that, I can do this, but I don't know what to do about it. And so a lot of what we are looking at with our work is helping to find out what can be done, what are some of the different tactics that we can go about this, and connecting resources and things that we'll talk about a little bit later. One of the things that we're actually measuring with our work is a PRAMS measurement that looks at the percentage of mothers to report that a healthcare provider talked to them about what to do if they felt depressed during pregnancy or after delivery. So not even waiting until mom is showing up experiencing the symptoms, but that universal education of what to do if this shows up for you. That kind of far end of the prevention spectrum. And so we were at 75% in 2011, which is pretty high if you think about it. That's 3 out of every 4 pregnant women or postpartum women that reported this. But then we also think about the fact that every 1 in those 4 will not receive this education. And if you take about 1 in every 9 women who experience this depression in Colorado, that's about 7,500 women a year, 7,500 births. So we're hoping to push that mark to be 80% in 2016. So in looking at the prevalence of depressive symptoms, we see that depression is more likely in women who experience trauma or stress prior to during the pregnancy, women who have their services covered by Medicaid, women who fall in the category of not married, and unfortunately our data collection system doesn't really let us identify, okay, are you not married but you're cohabitating with somebody, are you not married completely on your own? So really, you're either married or you're other, sort of a situation. And then women who fall potentially at a lower income. And all of these were considered statistically significant except for the federal poverty level differences that you see here. And we see that the experience, as many of us probably know, with many poor outcomes, that the experience of depression is not equitable. Like we've kind of noted, if you're unmarried, you're more likely to experience it. Only having a high school diploma, different race, being of a lower age when you actually become pregnant, having Medicaid pay for the services of delivery, things like that can put you at a higher risk. So the impact of depression on children. There's a growing body of literature that is showing that women who experience depression during pregnancy or the postpartum period can impact the social, emotional, and development of infants, specifically during that first year, but then even beyond that, creating social and emotional problems later on, which can also create delays or impairments in cognitive, linguistic, and social interactions, which then kind of snowballs to poor self-control, aggression, poor peer relationships, difficulty in school. Yeah. Go ahead.
I was wondering if you're hearing nationally that any Part C programs are starting to qualify families based on the diagnosis of maternal depression, given how much it puts the child's trajectory at risk.
You know, we have not heard anything on that on a national level.
Krista, you might repeat the question.
Oh, sorry. So there was for those of you that are on the webinar, there was a question about whether at a national level any of the Part C programs have actually used depression in the mother as a qualifying diagnosis for Part C services. And to the best of my knowledge, we have not seen that. I think that comes from a couple of different, probably multiple reasons, but one thing that can be difficult is that if child is being seen by the pediatrician and the pediatrician is the one that does the referral to Part C, if mom is not a patient of that pediatrician, there is this gap in terms of what they might check in with the mom, but what actually happens as a referral basis for mom can be a struggle because it's not their patient and what that looks like. But I think that if that question has not been put on the table of doing that, I think that it should be.
I would just say that Part C, which is the early intervention program, is specifically for a child that's experiencing a developmental delay. It doesn't look at mom's risk factors. So if these things, the impact on the child has to be diagnosable in a developmental delay. And what that delay is varies by state. Some have different eligibility criteria for that developmental delay when they go into early intervention, but there is no diagnosis of mom that then puts a child into the early intervention or Part C system.
Often as a provider, I've been able to get family services added once they've qualified because it's speech or
Right.
occasionally OT, whatever, but if the data just keeps stacking up, what's it going to take for us to say, oh, we want to wait to see the impact and then we'll provide the service?
Sure. And I don't know if anybody heard that, but you might repeat what Jane said.
So what Jane in the room said was that she has oftentimes been able to get the additional services added on once there is a diagnosis and the child is into the Part C referral system. But she raises the big question of what is it going to take now that we're seeing this growing research coming to the table that many of us could have said, well, duh, like, didn't take a rocket science to figure that out. Or maybe it did, but who knows. But what is it going to take to start connecting those systems of care and including mom? And I would say that on a national level, we're seeing more and more attention being given overall to maternal health because of that same there's so many connections that are being made to the outcomes and even what happens during the pregnancy to those outcomes of what happens with the child. And recently I read a research study that looked at an increased risk of children experiencing the depression themselves as adolescents if mom experienced depression either during the postpartum period or in their early years. So there's so much connection. So it's, you need to get that in the right ears of the people.
Advocacy. Question from Judy.
Judy on the phone has a question. I think they're all on mute.
They're all muted. She's not now.
Oh, Judy, are you not muted? Looks like, according to us, you're unmuted. Do you have a question? Well, maybe let's just check in with her as we move along. So one thing that we talk about a lot is what's called toxic stress. And toxic stress occurs when a child experiences strong, frequent, and/or prolonged adversity, such as physical or emotional abuse, chronic neglect, caregiver substance abuse, or mental illness, exposure to violence, and/or the accumulated burdens of family economic hardship, and if a child experiences these without adequate adult support. These more adverse experiences in childhood, or the more that a child experiences, the greater the likelihood of developmental delays and later health problems, including heart disease, diabetes, substance abuse, and depression. Research also indicates that supportive, responsive relationships with caring adults as early in life as possible can prevent or reverse the damaging effects of toxic stress. And so some of you may have heard of the ACE study, the Adverse Childhood Experiences Study. It's a huge national study that has really looked at what childhood experiences, how that impacts health later on. And so that kind of has drawn into the toxic stress and, again, raising that notion that things that happen very early in childhood can impact health outcomes later on.
What is the name of that study?
The ACE study, ACE, Adverse Childhood Experiences. If you Google it, the whole website will pop up. Yep.
Does the state just receive a grant, a large grant?
Yes, so there's a question in the room about the state receiving a large grant, and it's through our early childhood systems work with toxic stress. And conveniently, from the state level, the early childhood work is also in our program, so it allows us to kind of bridge that overall. But yeah.
A January summit.
I think there is, yeah. Yep. So more and more, again, and women who experience depression can fall into this category of toxic stress and what that looks like. So in looking at the risk factors for depression, we kind of have them fall into different buckets. And these are just examples of a few. Biological predictors, so having a personal history of major depression or familial history of major or postpartum depression, that in and of itself is probably the strongest risk factor indicator that we have seen throughout the literature that will put mom at risk for experiencing it either during pregnancy or the postpartum period. We've also seen growing literature around gestational diabetes, whether that is a physiological response that happens or the stress of having a chronic condition while you're pregnant and what that can mean for the woman. There's arguments for both. And then also women who have severe PMS or PMDD, and some of that is looking at the response to the changing hormones that happen and then also what happens after pregnancy. We also have situational stressors. Again, these are examples of an unplanned or unwanted pregnancy, complications in labor or delivery, difficulty with breastfeeding, sleep deprivation. The common question that gets asked is, are you able to sleep when the baby is sleeping? A new mom, if you ask a new mom, are you sleeping well?
No.
No, like, of course, that's kind of a usual response we're going to get. But the question becomes, if the baby sleeps, are you able to even lay down? And if not, then that in and of itself can be a red flag in your mind of, okay, we need to talk more about this because sleep deprivation is a huge risk factor for experiencing depression. Lack of material support, such as food and housing, kind of that lack of social support, major life stressors. The one thing I want to point out with situational stressors is that I think could also be important to this group is complications, that it's really perceived or actual. And I give the story of when my sister delivered my nephew, she was in labor for a pretty long period of time, about 29 hours total. And at the end, she just couldn't push anymore, and so they had to use forceps to get the baby out. Pretty routine for the hospital situation, and once they made the decision within 20 seconds, the baby was out. So my sister is a trial lawyer who does a lot of cases related to birth outcomes and things that get done in delivery. So for her to have that experience, for her perception, that was a huge complication. My nephew was fine. His head was a little deformed for about a day, but he was fine. But for her, that psychologically was a big thing for her. And so it's really that perception of what is the complication. It could be a mom who just had a birth plan ready to go, and all of a sudden she had to have a C-section. And that could throw her off. And so that perception is really what I want to drive home with you.
I don't know what OB took her as a patient.
Yeah. And co-occurring risk factors like substance and tobacco use, interpersonal or intimate partner violence, and we'll talk about a couple of those later on as well, because depression does not exist in a vacuum. And I think we all know that, and know that when we work with providers, this isn't a separate issue. It's along a spectrum of everything else that they're dealing with. Are we okay on the phone? Do we have any questions? Okay. Protective factors. So a lot of what the literature shows is that obviously having a planned pregnancy or a wanted pregnancy can be a huge protective factor for many things at large besides just depression. Having social support, and again, that social support is the perception of social support. So you might see a new mom come in with her mother who drives her to every appointment. So you might think, well, she has social support. Her mom is here. But if in that woman's mind, if her mom is not that, so if she does not perceive her as social support, that's where it's really checking in of who do you see as somebody that you can talk to. There might be people around you, but you might not feel that they're a support system for you in this process. Co-parent involvement, being confident as a parent, which we'll talk about a little later on with attachment. Obviously the things of eating well and being active. Adequate sleep can be a really hard conversation to have with a new mom, but the biggest thing is looking at if the baby is sleeping, have you been able to lay down for an hour? Giving yourself the okay that it's okay that I'm not going to clean the house, but I'm just going to lay down for an hour while the baby is sleeping. And if mom's not able to do that, that's where it takes exploring a further conversation of what might be going on. Supportive parenting decisions that align with the woman's cultural practices, specifically during that postpartum period, and women who come from non-Western cultures, and being responsive to what they might feel is important for them.
That's a really good point. It seems like the primitive cultures have solved this problem. My Somali friend, a grandmother, said, I don't know how to take care of a baby. When I had my babies, all the other women took care of them. I mean, you know, even though they don't take good care of pregnant women necessarily, so many cultures, the quarantena in Latin cultures, African cultures, most of them have 40 days for that woman to rest and recover. And we took that away.
And gave them depression.
I know, yes. So for those of you on the phone, there was an example given of a couple different examples of some cultures across the world and how they've really gotten it down where, for example, mom might have 40 days postpartum to really just care for herself and family cares for the child. And we in the United States are not necessarily responsive to that because of how all of our systems work, basically. Another thing that we've really pulled out of the literature is the support of a woman's decision on whether or not to breastfeed, which can be hard because and at the health department, we drive breastfeeding home that you should breastfeed as much as possible if you can't do it as the only form of substance for those first couple months for sure. But oftentimes there's also struggles that many women deal with, and so if a woman decides that it's not going to work for her to breastfeed long term, being supportive of what that decision means for her is a huge protective factor when it comes to postpartum depression. And some of that then goes back to parenting confidence. If she's sitting with a group of women that all say, why are you not breastfeeding? So she has had extreme issues with attachment or other things that have been going on, what that can do to damage her confidence of being a parent that she should have breastfed and she's not right now. It's just a huge thing to be thinking about. And then additionally, work policies that support breastfeeding and, you know, in an ideal world that provide adequate maternity leave and paid sick leave and time for mom to just be a mom. Oftentimes returning to work early can be a protective factor for mom if she's surrounded by other women who have had to do the same thing. Or it can also be an extreme source of guilt for her if she's had to return after 6 weeks or after 2 months and she's still trying to breastfeed and figuring out how to deal with that. So many complicated issues. So the Strengthening Families framework, this framework is actually protective factors that are associated with the prevention of child abuse and neglect. And we find that there are many correlations here with the protective factors associated with the prevention of PRD, or pregnancy-related depression. Specifically, social connections, knowledge of parenting and child development, and concrete support in the time of need. So we're going to walk through a couple scenarios. So let's say that a pregnant woman comes into you as a provider, and she has a history of depression. She's lost her job the same day that she found out she was pregnant, and she's not been able to find stable work since, maybe here or there. You've noted that the partner who is ever the father of this pregnancy does not want anything to do with the pregnancy or the child that will result from this. And she has noted that she has been unable to sleep, she hasn't been eating right, she's looking pretty frail, things like that. So what are some of the risk factors that you see here?
All of
the audience. So pulling out if she has a history of depression, that should be a huge red flag to begin with, and start talking to her about what that looks like for her. Has she been seeing a provider? What's the history with it? Definitely the fact that she doesn't potentially have a stable source of income right now and what that might be as a social stressor to her. And then looking at the fact that she's not eating or sleeping. Just eating well and being active is a general protective factor for all of us with regards to mental health, and that in and of itself can be a downward spiral. Oh, hold on, we're going to figure out how to work the, there we go. Okay, a different scenario. So let's say that a healthy pregnant woman comes in. She's pretty excited about the fact she's pregnant. She's just bought a house. She talks about the fact that she's already decorating the baby's room. Her family lives close by, and she knows that she depends on her mom a lot for support, and that her and her partner both have stable incomes. So in switching a frame of mind, oftentimes you're not going to have these pretty easy scenarios. It's going to be a mixed bag. But being able to think about some of the risk and protective factors and things that you can pull out and really start to talk more about, mom is a constant support system. What type of support does mom provide? Have you found you can talk to her about certain things like that? The fact that, her and her partner seem to be doing pretty stable. It seems like it's definitely a wanted pregnancy thus far. They just bought a house, being excited about the upcoming baby. But those are things that also we find within clinics and practices can also kind of be discussion points within providers themselves of the women we see. Are there things that we're seeing that they're talking to us about that can either become risk factors or protective factors, and how can we engage women in talking more about those things? So attachment. So there's not a mom out there who doesn't want to have a good attachment with their child. Attachment refers to the emotional connection that babies form with their caregivers, and these attachments are built on shared experiences that happen over time out of a sense of trust and connection. And so it could be laughing together, it could be making eye contact with each other, those very simple things that happen very, very early in life. And healthy attachment supports the baby's social and emotional development, so this is really where it is all starting down that whole train line of snowballing. And this healthy attachment develops when a mom is able to respond to a baby's cues in a dependable way. And so this is from Kate Kripke, who is actually located in Colorado. She's in Boulder. She runs the Postpartum Wellness Center of Boulder. She's also a state co-coordinator for Postpartum Support International, which we'll talk about a little bit later. And she blogs a lot on the Postpartum Progress website, which we'll also talk about. But she is one of the great local experts. If healthy detachment if it's disruptive or it fails to form entirely, this can often happen with women who are going through depression during the postpartum period. They're not able to attach to their child and to respond to those cues as dependably because of other things that they're also dealing with themselves and struggling with. So this also comes from Kate Kripke, and these are questions that she wrote in one blog about attachment and things that helping a mom kind of think through. Can I spend at least one short, specific period of time each day looking into my baby's eyes, playing and encouraging laughter? Can I bring in support when I notice that my baby has a need that I cannot meet, maybe because I'm doing other things on my own or I'm struggling? And what do I do to need to take care of myself so that I can be present and consistent with my baby as possible? So these are just examples of questions that can be reflected back with the mom. And oftentimes, not being able to respond to, it becomes a cycle, so not being able to respond to a baby's cues can affect the parent's confidence. And then if mom fails to be able to respond to those cues and mom has a decreased confidence of being a good parent because she's not able to respond, then mom's confidence decreases, potentially depressive symptoms could increase, which then also then fails for her to respond to future cues. It becomes this cycle of things that are happening. So the earlier that it's caught, the earlier that it's noticed, the better off everyone is. Yeah?
I'm just going to say that the slide before you were talking, those good questions, and that's setting aside some time during the day, and a lot of parents have said, I don't have the time, I don't have the time, and it's just 5 minutes. And maybe that's repeated a couple of times during the day.
Yep.
So it's I like how you keep talking about perception. So the perception that it must be this giant chunk of time that will put everything else off schedule when it could be do everyday routines and just little snatches.
So we had a comment in the room from Jane, from Jane that was saying that really that perception is key, and oftentimes when talking about this with moms, that moms have that perception of, well, I don't have time, but taking that maybe just 5 minutes and that perception of what does that chunk of time mean? Is that really an hour? Is that 5 minutes out of a day? If mom feels that it's extremely important that the house is clean, okay, well, let's recognize that that's an importance. Is there somebody that can help you with that you can have 5 minutes with your baby to work on this? Like, what other support systems do you need? But really, that perception and that maybe it's just small pieces of time throughout the day. Okay, so here are some other risk factors that we'll talk more about. So oftentimes, anxiety is oftentimes a comorbidity of depression. From what we hear in the field and what we've looked at ourselves, you're going to see both together. It's usually not one or the other. The depressive symptoms might be kind of the predominant thing, but anxiety is most oftentimes there. Obsessive compulsive disorder can also be considered a co-risk factor. Obviously, tobacco use just overall, either during pregnancy or a woman that goes back to it right away postpartum, just as another risk factor that's happening. Intimate partner violence or interpersonal violence, it might not be a partner, but those stressors that are happening within whatever living situation or social situation she's in. Drug use and alcohol use are huge. If mom is using substances either during pregnancy or during that postpartum period, it's likely there's other things going on as well. It might be that the substance use is driving the mental health issue. It might be that the mental health issue is driving the substance use issue. Goes hand in hand. History of trauma or abuse overall. Another thing that we've looked at is bipolar disorder, which is not a risk factor, which is why it's not up here. But women who, so if a woman has bipolar disorder, she's more likely to have an experience of that disorder during the pregnant or postpartum period. Or if she's at risk for it and becomes diagnosed with it, it's more likely to happen during those reproductive years, whether it's pregnancy or postpartum. And so I bring that to light here because oftentimes people will screen for depression, automatically think it's the depression issue and get put on depression medication, but in reality it might be bipolar disorder. And so making sure that there's that second check of it's caring for women who are dealing with bipolar or dealing with some of these issues, screening for depression, but also taking that second step in those who are qualified screening for bipolar disorder to make sure that it's not that that's coming into play. So depression is usually called, could also be called unipolar disorder, so it's more of just the down. Bipolar disorder has those extreme ups and those extreme downs. So you want to make sure overall that it's the right condition that the woman is diagnosed with if she needs to be diagnosed so that she's cared for properly.
So Krista, why don't you have a comorbidity of like the bipolar versus the unipolar on the
Because a woman who is diagnosed as being bipolar is not also going to be
depressed.
Right.
Okay.
Oftentimes a woman who's depressed can also have anxiety.
So the risk factors here are for depression risk
factors.
factors.
So these might be happening along with depression. But I bring up bipolar because we've seen it where it's women are automatically everybody jumps to depression.
Right.
But then that second step of screening, making sure that it's not the risk factor for bipolar disorder and caring for them. What you don't want is to put a mom with bipolar disorder on an antidepressant because that's not going to end well in terms of her treatment plan. So, but oftentimes a woman who might be experiencing depressive symptoms may also be using tobacco, may also have anxiety, could also be using alcohol. So they're occurring together.
Okay, thank you.
Are we okay on this one? Do we have any? Okay. So specifically, substance use and domestic violence. So research shows that the experience of intimate partner violence, or IPV, or domestic violence, can strongly increase the risk for experiencing pregnancy-related depression, and this holds true in Colorado as well, where we see that 25 to 30% of women who report intimate partner violence either before or during pregnancy also report signs and symptoms of pregnancy-related depression. So I'll repeat that one more time for those in the room. In Colorado, we see that 25 to 30% of women who report intimate partner violence either before or during pregnancy also report signs and symptoms of pregnancy-related depression. They are also more likely to use substances, compounding the issues even more. Depression alone can lead to adverse pregnancy outcomes, but in combination with intimate partner violence and/or substance use, the effect is exponentially greater. So the challenge becomes how providers and community programs then address these issues in a way that is not done in isolation. And that's a challenge for all of us, and that's why a lot of our state work we look to partner with others, because we're not in a vacuum alone in isolation with our issue. Okay, so what to do? So now that we have all this information, we're going to talk a little bit about what the state is doing. So we are funded by MCH funding, which falls under Title V. And our kind of big goal is to promote screening, referral, and support for pregnancy-related depression. And as I talked about before, that percent of mothers that report that somebody told them what to do is really how we're looking to see if we're moving the mark at a statewide level. Some of our strategies include advocating for improved Medicaid and private insurance coverage. So an example of that is right now within Medicaid, adult depression screening is not reimbursable. It is reimbursed for children, I believe, ages 9 to 21 or 11 to 21. So if there's an adolescent teen mom that gets pregnant, obviously that might be reimbursable, but there's not in terms of the general adult depression. We don't find that to be the main driver of why people are not screening. However, when you look at data and you need to be able to pull numbers and push the mark even more, having reimbursement for the time and effort is extremely helpful. So we're still working through that and seeing if there's other ways that we can start to leverage this in the public sector, and then private insurance is a whole another beast that we will look at as well. Developing a coordinated approach across systems. So again, hitting home that this does not exist in a vacuum, and working with others, and also getting others to work with each other. So connecting providers with community programs, which this is all of what this is all of what you're doing, but really getting the word out there and connecting those local resources. Developing a statewide coordinated effort to train and support providers. So there's no specific designation to be a maternal mental health specialist or perinatal mental health specialist. It's just based on the education and the focus of what that specialist has chosen to do within their practice or within their field. So looking at how we can support getting information out there about those who are experienced in this field and what that looks like for them. And then raising public awareness. We've actually chosen to kind of push the public awareness to the end of what our multi-year work will look like, because what we don't want is to push public awareness towards a system that isn't equipped to handle it. So if you push awareness on an issue before a system is ready to deal with the issue, you're creating potentially awareness in a population that isn't going to get help for recognizing that something isn't how it should be. And so that's kind of why we haven't gone the traditional public health route of always just pushing public education, but really making sure that a system is ready for it. And our ultimate desired impact is obviously early detection, increasing the rate of treatment. And the treatment could be pharmacological-based treatment, it could be mental health-based treatment. We actually don't get into the specifics of what treatment should be provided versus not, because we don't feel that's our role in public health, but we do feel that adequate rate of receiving treatment, whatever is needed for that specific woman, is where we can help kind of push the mark. And not even just the referral to treatment, but the mom actually going to get the treatment. So it's one thing to get the referral, it's another hurdle to get over to get mom to actually go. And then decreasing health disparities, especially among those who exhibit potentially a higher risk for developing these symptoms. So some of our current projects that we'll talk a little bit about, when we first started, we spent about a year of our work just figuring out what was happening on the national level and the state level, because we really wanted to be intentional about how we move this forward and not operate in a silo by ourselves. So we'll share a little bit about that. We'll share a little bit about some supplemental guidance we've developed with Health Teamworks and where we're hoping to move forward with that. some professional development, and some systems coordination. So in January, don't worry about trying to read this map, I'll explain it to you. So in January of 2013, we released a statewide survey to anyone and everybody that we could think of that quote-unquote touched a pregnant or postpartum woman throughout her care to identify what was happening currently in their communities. Were they screening? Did they use a screening tool? Were they referring? Where were they referring to? How were they referring? Kind of the whole gamut. We also spoke to early childhood folks and family planning folks as well and included them in that spectrum. We had just under 600 responses. And we had them answer. We asked individuals within agencies, but they reflected back on their agency's work, not necessarily what they themselves as an individual chose to do, because it really comes down to what's happening within the agency versus what you, as potentially a superstar in your work, think that you're going to do. And so one thing that we captured was the strength of screening processes. So you'll see some red dots on the map. The red dots are what we have indicated as a weak screening system. So this agency or program might talk with some women about how they are feeling, but they may not converse with all women that they see. They may use a screening tool, but they're most likely not using it with everyone. A moderate screening system we identified as agencies that do use a formal screening tool with women, but they don't necessarily discuss results with everyone. So they're only really discussing results with women they feel need it versus explaining it to all patients they see. And then a strong screening system is that the agency or the program uses a formal screening tool with all women, and they're also discussing the screening results. Not only delivering the tool, but it's understanding what does this mean for this woman. And so rather, we, in our questions, this is in terms of the three kind of different buckets, we kind of figured that out internally as a program as to what we felt made each kind of level. Because we couldn't find a national indicator that looked at this. So the more important thing to take away from this is that you see a scattering of shapes across the state. You see green stars and you see red dots that are in the same county, potentially in the Denver metro area very close to each other. So there's a lot of peer-based learning effort that can be done outside of what we as the state can give as a top-down approach, which I think is key because really those who are working in the field are going to be able to teach each other best as to what's actually working. We as the state can just help support and give that supplemental guidance, but that peer-to-peer learning is huge, I think. Okay, so we have a very similar map. Another thing that we looked at was the strength of referral processes to external agencies. So this was an agency who was going to refer to somebody outside of their system, so not having co-located services. And what were the activities that they were doing? And again, a weak referral system we identified as an agency or program that provided information on maybe a local mental health agency, but they didn't necessarily do this as a standard process with all women. So some women may get some piece of information based on who they see. Other women might get different information based on who they're seeing that day. There wasn't really a standard process. A moderate referral system was a program or agency that provides that basic information, but does also provide a name and contact information or instructions on how to make an appointment. So kind of that additional level of, you're going to go to X agency, you want to connect with this person, here's their name, here's their contact information, kind of building up that rapport with them. For those that are the yellow diamonds as a moderate system, this is a standard process that they do at least for all women who identify as high risk. So there's some sort of agency level policy or process that for all women that they've determined as high risk, which might have some arbitrary analysis to it, we're going to get this level of information. A strong referral system that we noted, the green stars, were that they're doing, all those agencies and programs are doing what the yellow diamond indicates in terms of providing that additional contact information, but they're oftentimes also completing an active referral by calling on behalf of a woman and setting up an initial appointment, or somehow engaging that woman in that active referral process. And that these activities are done as a standard process for all women who identify high risk. And if I could give a superstar mark of another shape, I would say that the strongest referral system is going to be one where there's a feedback loop of communication. Again, because it's one thing for me to refer to Barbara, but it's another thing for the woman to actually go and for Barbara to be able to connect back to me and say, hey, this patient never showed up. I'm going to see her next week in my office. I can follow up with her and say, okay, you never followed up on this appointment. Let's talk about this a little bit more. What barriers are preventing you from taking it to this agency, whatever that might be.
Krista, this is Jane, and they've done some work in the early intervention program about families that get referred to services, and that sometimes it takes up to 7 times to hear what say a family should be doing as far as the referral for their child with a developmental concern. And of course, we know moms and dads want to do what's best for their children most often, and all of the, you know, maybe 100% of the time, but to actually follow through on the referral for the early intervention services, it could, and we know there's lots of reasons for that, but they've done statistics that it takes up to 7 times for a family to hear that they should go to that referring source, why, and then follow through with that. So I was just going to bring that up as your superstar feedback loop piece, that is often what we also need to do is, and that community continuum needs to do, is to reinforce that referral, making sure that families and are most, that they are continually being referred to the right place at the right time and for what reason, and having that reinforced.
And some of that can also, I completely agree, and some of that can also within the mental health realm, across the state with many of the mental health centers, there's a wait, potentially significant wait for somebody with depression, and it's not that pregnant women or postpartum women get priority. Sometimes they might, but not always. So being able to check back with that mom of, okay, I have an appointment, but it's 3 months from now. Well, what's going to happen in that 3-month period, and what can we do to help get you to until you can receive that appointment? Are there other resources in the community that we can get you hooked up with to help increase social support or interaction or things like that? Another thing that we looked at was, where are you referring women? Because we know that people are going somewhere, and there's oftentimes local resources that we just don't know about. So this is also a pretty confusing map. Each of those circles is actually a type of service. So a hotline, counseling, education, and support, that could be a mommy and me group, it could be a parenting class, it could be a lot of different things. And then kind of the more intensive referral services of medication management, consultation, psychiatric services. And then the purple circles are where all 4 of those are located in one agency. So what we see is that there are certain things across the state. We also see that there are also some big gaps. And so that helps us kind of look at, where can we work more intensely with some communities? Where do we see neighboring communities? They've got certain services hooked up in their community. Can we learn from them? Can we partner communities together to learn from each other, sort of a thing?
I'm really impressed by our eastern counties, how they seem to have it all. All 4 types within one agency. However, on previous maps, they're not screening.
Yep.
A little disconnect there.
Yeah,
a little disconnect.
Services to the people they figure out.
Right.
Just have to be,
we need to help them figure them out.
That's
it. You probably have to be pretty bad before you get there.
It could take that provider who has checked in with a mom at a visit verbally, and that's who he's sending, but those 5 other women that he saw, he maybe didn't check in with them because they looked okay.
Right.
I don't know what looked okay might mean, but you know, that discrepancy of what does it mean to screen women. So combining resources, this really speaks to our ability to really want to connect with other issues. Are any of you familiar with linkingcare.org? So linkingcare.org is a source that comes out of the Office of Behavioral Health at the Department of Human Services. And it was first built as a substance use site, and so people can go on and take a brief substance use screen and then find substance use providers that are within their area. And there's different criteria they can look on. Do they accept women, inpatient, outpatient, things like that. This all came out of a SAMHSA grant. They're pushing to do
Omni.
Yep, with the Omni Institute. Omni Institute is the one that is housing this website. They want to push to do mental health as well, and that's kind of their next stage. And so we've come to the table to say pregnant and postpartum women need to be offered services that speak to them, and they need to be provided a screening tool. The PHQ-2 and the PHQ-9 are both validated for pregnant and postpartum women, which is an option, but the Edinburgh Postnatal Depression Scale is also one that speaks directly to pregnant and postpartum women. And so we're working with them to build that tool into the website that women can take that will give them feedback that is really cultivated to speak to them as a pregnant or postpartum woman and some of the stigma they might be dealing with. So hopefully that will be coming soon. And then we're hoping to partner more with 1-800-CHILDREN, which is a helpline, family and parenting helpline, and hoping to work with them more to connect pregnancy-related depression resources and training. It's sponsored by Prevent Child Abuse Colorado and has is currently being promoted by the Colorado Drug Endangered Children Agency and the Substance Exposed Newborn Efforts. That's a lot of information in 2 sentences. But really looking at it, if parents are calling because they're struggling with other parenting issues, maybe it would be helpful to also connect this issue with them as well and make sure that it's on the radar of people who are answering calls and providing appropriate resources and information for them as well.
Families First is actually operating.
Oh, Families First is operating the line.
But it's started by Child Abuse Colorado.
So for those of you on the phone, Families First is the one that is operating the 1-800-CHILDREN line, and it is sponsored by Prevent Child Abuse Colorado. So Every Mother Initiative, just a quick look at, so we house the maternal mortality review work within our program, and we review maternal deaths that happen each year. And so we have been funded to take an increased look at, part of our work is looking at suicide, substance overdose, and intimate partner violence homicides that happen over the year. We don't see a large number of maternal deaths each year. It's nothing like what you see with child fatality. But among those that we do see, we have anecdotally noted that suicides have started to increase. So really being able to learn from those and then take that into data to action and actually host focus groups or in-depth interviews with women who may have been suicidal at one point or may have gone through depression to identify what actually worked for getting you into a system of care. So rather than glorify risk, look at what actually worked for you. Was it in a system of care or was there something outside that actually promoted you to get the help you needed? And what can we learn from that as successful intervention points and teaching points for providers so that you potentially in the future have more near misses versus maternal deaths. So part of our work with Health Teamworks has been our pregnancy-related depression guidance. We just got through our first year. During this year, we brought between 40 and 65 individuals to the table from across the state that were experts in OBGYN, pediatrics, early childhood, pharmacology, private and public sector mental health, psychiatry, you name it, they probably came to our table at one point or another. And that was really because we noted that there was the need for supplemental information and guidance within both the clinical and community-based systems. And so we brought those experts to the table to identify what was needed and how can we best format this and bring this back to the community. So this is the document. The difference with this document, if you've ever worked with a Health Teamworks guideline before, usually those guidelines, everything that you need to know about an issue from top to bottom, step by step, is within this 2-page document, which can be a lot of information, as you can tell from this. This document operates somewhat the same way, yet there's different chunks of it that will speak to different types of providers in the community. So if you look from left top to bottom and then right top to bottom, on the left, that first page can really be used by community-based programs, individuals who might not be caring for women who are depressed, but come in contact with pregnant and postpartum women. Could be your lactation consultant, your doula, your home visitation, health educator, WIC, things like that in terms of starting conversations, looking at the difference between depression and baby blues, risk and protective factors that go more in depth, and then things to consider if you're going to be offering screening. The back page is really for those who are going to do the more clinical assessment and or care and management of a woman who is dealing with depression. So looking at that flowchart on the bottom that you can't fully see is actually a medication flowchart done by the pharmacologist looking at pregnant and or breastfeeding, and they're requiring medication and things to think about. Kind of that general circle is all lifestyle considerations. Other things you should screen for, so you see that anemia and thyroid disorders, if you screen for depression, those are other things you're going to look at because they can oftentimes mimic some of the depressive symptoms. Bipolar disorder, psychotic symptoms if they are in that postpartum psychosis, which is rare, but you want to make sure that you screen for that right away, looking at engaging the patient as part of this process. So it's a big document, but I think it has multiple uses in different venues in terms of the pieces of information that you can pull from it. We are going into our second year of implementation with this and are actually looking to pilot it in different settings to identify some informative research on our end of what the next steps are and how to develop some supplemental material. So my contact information is at the end of this, and if that's something you're interested in exploring further, we would be working with Health Teamworks and then your clinic or program to do some training and then partake in some feedback for us of what's working and what are challenges that we can then move forward in the future to provide more support. So these are some of the starting the conversation questions that we won't go over too much here, just to be sensitive to time. We do have an upcoming summit on perinatal mood disorders. We are at a wait list of 50 individuals right now, which is great. I think, though, what that has shown us is that we need to have some more sustainable training opportunities, and that's what we're going to be looking at as well, because definitely the need is there. But we're bringing in folks from, we try very much to get local folks to identify and highlight those local experts in the field that can come to the table and talk through some of these issues. Kathy Wells will be there. I believe she's talking to you all in January. So she's going to be discussing how to engage successfully with the child welfare system, CPS, especially CPS gets called on a mom who's neglecting her child due to a mental health issue. That actually damages it even more, because what she needs is mental health to be addressed, not necessarily. So how do you engage in that very complex situation? And so Kathy's going to talk to us a little bit about it as well as just one session. And then we'll just briefly jump through these. Like I said, we talked about toxic stress. This is some of the work that's coming out of that grant that we house the early childhood efforts as well within our program, and so this allows us to really tie into some of the efforts that are happening in the Early Childhood Comprehensive Systems grant. And then ABCD, which is Assuring Better Child Health and Development. We work closely with them in terms of they're pushing for increased screening of social, emotional, and developmental issues. Ideally, if mom comes to a pediatric well-child visit and there's potentially a red flag raised on one of the social or emotional screens that happens, the first thing the pediatrician should also do is look at mom and say what also might be happening with mom as part of this process, because there is such a connection there. Yes?
And this is a screening tool that you could add to where you're putting the ESBA as well, which is the PSI, the Parenting Stress Index.
Yes.
It really highlights, is the problem within the child, is it within the parent, or is it within the relationship?
Great.
So that it gives you a better idea of what kind of treatment.
Perfect. So there's a comment here in the room that there is a screening tool out there that could be used for this type of situation called the PSI, the Parenting Stress Index, that can help you identify, is the issue happening with the child, is it happening with the parent, what's the connection to it. And I think that that's great and one thing that we can also promote. And then just partnerships in local communities, connecting early childhood councils with local public health, LPHAs and mental health centers, mental health and medical providers and community-based programs that are happening, making sure that everybody is kind of connected with each other at a local level. And then very quick, in my 1 minute that I have remaining, I do want to highlight Postpartum Support International. They have a weekly call-in group counseling support service that happens every Monday that's led by an experienced professional. Women from across the nation can actually call in. So this is free. It's a great first step if you're in a place where mom has some challenges with actually getting services. They offer one for dads as well, too, that is the first Monday of every month. Again, they're all held by professionals who are experienced in this field. And then they also have local state coordinators, and these are all the ones for Colorado. A mom can call their number, and they will help identify next resources for her and check in and support with her. These are all free. Many of these people, you'll see Kate Kripke on here. Jen Adams is also on our advisory committee, so I think that this is oftentimes the resource that we don't use as much. But these are also individuals who all work within the field of reproductive mental health. And the other one is Postpartum Progress. So this is a blog that is run in a nonprofit that's run by a woman who experienced postpartum OCD. So oftentimes if a mom is experiencing symptoms or told you might have postpartum depression, if she's tech savvy at all, the first thing she's probably going to do is go Google it. And oftentimes that can put them in a position of getting resources that maybe aren't as supportive as what she might need at this point in time. This would be one resource that I would absolutely encourage you to give, because it's survivor and support stories from women who have gone through these experiences. And so it's definitely one that is monitored also by experts in the field. So if information is put on there, Catherine Stone is actually makes sure that that is appropriate information and goes through experts that are on a national level. But it's absolutely a warm and supportive environment that I would promote as being okay to give to women, as this might be something you want to check out if you're looking to read more about others' experiences with this. And so by promoting optimal maternal mental wellness today, we have the potential to impact the health of tomorrow's generations. That is my contact information, and that was a lot of information within an hour. So if you have follow-up questions, please let me know.
Well, what, Chris?
It's on the back page.
Krista's information is on the last page of the handouts that are going to be going out. This is Barbara DeLoyne again. And we will see that those that slide presentations are available to you. And also we would like to have you respond to a survey on sort of evaluating the program today and our, getting ideas for future programs. So I want to thank you all very much for your participation, and we hope that you will join us in January, Wednesday, January 30th. And as Krista said, Dr. Catherine Wells will be talking with us about substance abuse. Thank you. And it will most likely be here at the Colorado Department of Public Health and Environment, and we'll give you directions to that in future notices. Thank you very much.
That's great. Very informative.
It's a lot of information.
It is a lot of information.
Bravo, ladies.
This is great.
Excellent.
Do you know if any of these websites are available in Spanish?
Hold on.
This is not one you can screen share.
Stop it. Report in progress is not in Spanish.
Okay.
But I think there are PSI presentations.
Okay, perfect.
They're international based.
Oh, okay.
And they also have a lot of research.
Okay, perfect.
But I think the phone-based support group